Thank you very much, Martin, for your great talk. There are a number of questions. The first one was whether you also find EEG abnormalities in the late onset NMDA receptor encephalitis patients.
Yes, the abnormalities on EEGs are not different between patients that are young or older. So the late onset patients show the same amount of abnormalities, and this is about a little under 90% of patients with NMDA receptor encephalitis late onset will have EEG abnormalities.
Okay. And another question was whether you have seen GABA B in association with stroke.
No, GABA B is a pure limbic encephalitis, and most patients show full-blown seizures or rapidly progressive cognitive deterioration. I've only seen one patient with GABA B encephalitis and stroke, but she developed her stroke 10 months due to a herpes simplex vasculitis, probably due to all the immunotherapy we provided him to treat his GABA B. So that was a complication of the treatment we provided, but nothing directly to do with the GABA B itself.
Okay. And another very interesting question is in patients with NMDA receptor antibodies and negative pelvic MRI or ultrasound in female patients, what is the interval when you make another scan to test whether you find a teratoma?
This, of course, depends on the patient. If you're talking about the typical patients, so let's say a woman 12 to 45, I would repeat the pelvic scan or MRI depending on the clinical situation. So if your initial scan is negative, but your patient is not improving, I would repeat it in 3 months to see whether there is a occult teratoma that might have become visible as you screen again or due to the immunotherapy you have presented. So then I would see whether this is persisting the immune response and therefore keeping your patient refractory to your immunotherapy. If you have a patient that improves to immunotherapy, I would repeat after 6 months and maybe afterwards every year, because we're talking about a very low grade, not really a malignancy. So it is slowly growing, and it's probably not necessary to screen every 6 months as you would be if you would screen for more malignant tumors like a small cell lung cancer, where you would have to screen every 6 months. So then I would screen probably every year, and when patients develop relapses. In patients over 45, you're not really looking at ovarian teratomas, but you're looking at ordinary tumors like thymoma or small cell lung cancer. And then under the age of 12, where the chance of having an ovarian teratoma is very, very, very low, it's even questionable whether you should repeat screening after your initial screening is negative, as the chances are that low, like 3 to 4%, and after initial negative screening, this probably drops still under 1%. So maybe only when they relapse.
Okay, thank you very much. And there is another question in a patient with psychiatric symptoms, but without fever on presentation. What is your clue to suspect autoimmune encephalitis?
Yes, this is, of course, a very difficult question we get a lot, maybe every week or so. It's important to consider whether it's psychosis or schizophrenia. If a patient already suffers from schizophrenia for many years, your chance of actually finding autoimmune encephalitis is much lower than when you're talking about the first onset psychosis. And generally, it might be dependent on other symptoms. It could be subtle movement disorders, it could be tachycardia, it could be fever, even, well, you said there was no fever in this patient, but um, um, I would see how they would respond to haloperidol if they have extrapyramidal side effects, and only very minor doses of antipsychotics. That would be a trigger. If they have another autoimmune disorder, they might have an increased risk of actually having an autoimmune disease. And catatonia or refractory depression. So if patients would otherwise go for ECT, you might consider to test for antibodies. And especially if you still want to do your ECT, they're under narcosis anyway, so you could quite easily do a lumbar puncture to test for antibodies. And it might be important if you really consider NMDA and NMDA turns negative, then also consider AMPA receptor because it's also related to psychosis, especially in older patients.
Okay, very good. And there is another question coming in, which says, when you have a patient with gut antibodies presenting with stiff person syndrome, can such a patient later also additionally develop limbic encephalitis?
Yes, gut antibodies, as the high titered, high concentration gut antibodies are related to different clinical syndromes, one of them being stiff person syndrome, the others three major syndromes being cerebellar ataxia, epilepsy, and limbic encephalitis. And we don't know why, but patients can develop the different type of symptoms in different years. So they might present with stiff person, but 5 years later develop ataxia or develop limbic encephalitis. So yes, that's possible. And we also know patients that started with epilepsy and then 10 years later developed some symptoms of stiff person syndrome.
Okay. And now there is another question with gut antibodies, which is often, that I also often hear is, patients often do not respond very well to immunotherapy, but what would you recommend for treatment in patients with gut antibodies, corticosteroids or immunoglobulins or something else?
Yes, well, of course, it's very difficult. Gut might be one of the most difficult antibodies to treat. There is, of course, the difference between high titer versus low titer. So if you're looking at high titer antibodies, and most labs use an ELISA, and then we're talking about 10,000 units, international units per milliliter in serum, or 100 for CSF. So we're talking about very high titers, then it's probably directly associated with the neurological syndrome, and it's still, it's not probably not a pathogenic antibody mechanism. And what we see is that about 2/3 of the patients do respond to immunotherapy. However, this response is partial, so patients do not get completely seizure-free. They do not improve completely, but partially. In my experience, IVIG is more effective than steroids, and steroids have much more side effects than IVIG. But there have been no randomized controlled trials. We do use rituximab for gut these days as well. Some do respond, some don't. So it's a very, very difficult disease to treat, I would say, but at least we try.
Yeah, well, yeah, this is also our experience in Vienna. And well, I have here several questions regarding LGA1 encephalitis. So there is one question that says there is a patient who responded to the immunotherapy but 1 month later he worsened again. So what to do in this case? And another question says, how long should you continue with immunotherapy in a patient with LGA1 antibodies, especially if the antibodies are persistent, so they are continuously positive in the follow-up testing?
Yes, well, to start with the duration of immunotherapy, we do not really know, but we do know from studies that did not use standard immunotherapy that the relapse rate is about 30 to 35%, while the studies that used standard chronic immunotherapy had relapse rates between 5 to 10%. So it seems that azathioprine or mycophenolate, those steroid-sparing agents that we also use for myasthenia, have an effect against relapse rates. And I have to admit that when we started using it, our relapse rates also dropped from 30-35% to 5 to 10%. How long should you treat? There's only one study from China that actually looked at 1 year chronic immunotherapy, and the relapse rate, I'm not sure whether it was actually published. I saw it as an abstract, but the relapse rate was still about 30%, 35%. So apparently 1 year of treatment is not sufficient. What we generally do is treat for 3 years, then check the antibodies and discuss with the patient what they should look for, and then we discuss whether they want to taper it down or not. Some want to get rid of the treatment and some want to continue, and then we just watch and see. If we do stop treatment, we do determine antibody levels 3 months and 12 months later to see whether they do develop antibodies later on when the medication stops. And one other issue in this decision making, next to what the patient wants, is also the type of symptoms they had with the initial episode. LGA1 is in a way an easy disease, as the relapse is always the same as the initial episode. So if the initial episode starts with facial-brachial dystonic seizures, tell the patient and the family to look for those symptoms. And when they develop them, you can redose them with immunotherapy before they start to have cognitive symptoms. However, there's some patients that start with very early or very prominent cognitive symptoms, and then I would be very much more wary of getting them off treatment, because if they relapse in the same way, you probably have permanent cognitive damage. Mm-hmm. So that's about the long-term treatment. What about relapses? We have a few patients when you start, we always taper them with 60 milligrams of steroids for like 4 to 6 weeks after the initial steroids in IVIG, and then taper it down in like 7 to 8 months, 7 months probably, while starting on azathioprine or mycophenolate. And I have to say, we don't see that many relapses using that scheme. But if they do develop, for example, a relapse while you are on 25 milligrams of steroids, it means you will never get rid of the disease with only mycophenolate or azathioprine, because that will not be sufficiently depressing the immune system. So then there might be two options. There is a tumor, and that's causing the immune response to persist, or you need more aggressive immunotherapy. So we do another screening round with the early relapse, and then we start rituximab to avoid, to get it down together with steroids. Mm-hmm. And it seems to work, but that's not trial-based.
Yeah, okay. Very good. Thank you, Martin, for this very good answer. There are other questions like, what do you consider, so is PET a useful tool in the diagnosis of autoimmune encephalitis, or are there any benefits of PET scan?
Do you refer to the brain PET scan, or do you refer to a body PET scan?
I think it is the brain PET scan they are asking for. But maybe they are asking, it was not specified. Maybe you can say to both.
Okay. Yeah. Yeah. Well, the frank answer is we don't know. There are some groups that advocate the use of FDG PET, but and they say that it's more sensitive than MRI, and we do know that MRI can be normal, especially in NMDA receptor encephalitis. However, we do have antibodies to detect NMDA, and we do have EEG. It has never been shown that FDG PET actually is more sensitive than EEG to detect autoimmune encephalitis. And the main problem of the PET scan is not only the sensitivity, but it's the specificity. Of course, it will help you to detect a autoimmune encephalitis versus a healthy control or a primary psychiatric disorder. So in that way, it sometimes might help. But it does not discriminate in most cases between, for example, a neurodegenerative disease and autoimmune encephalitis. If you identify hypermetabolism, for example, in NMDA receptor encephalitis, yes, that's helpful. However, for those, we have antibodies to detect. For the if you're considering about, for example, seronegative autoimmune encephalitis, the patients that have been published are mostly showing hypometabolism in more patients than hypermetabolism. And the hypometabolism does not discriminate so much with neurodegenerative disease. So I think, although FDG-PET is very exciting and it's a very nice research tool, in clinical practice, I'm not so aware whether it's that useful. We do use it sometimes on the psychiatry ward if we really are considering whether this is a primary psychiatric disorder or whether it's a neurological disorder, but then often it does not help us to say whether it's neurodegenerative or inflammatory or autoimmune or viral and so
on. Okay. And another question, I think this is very important because we hear this again and again in the congresses. So would you consider removing the ovaries in patients with NMDA receptor encephalitis that do not respond to immunotherapy but have a negative scan?
The simple answer is no. The extensive answer is a little bit more nuanced, but in many patients, we do know that the response to immunotherapy is slow. So only half of the patients will respond within 2 to 4 weeks to your immunotherapy, and the other half will take longer. The sensitivity of your screening methods using ultrasound, using MRI is over 90%. So even the group with the highest chance of having an ovarian teratoma, so let's say a woman of 20, who initially has a chance of 50% of having an ovarian teratoma, with adequate screening, only 5% of the patients will have 45 will be detected by initial screening and 5% won't. This is the 55% left. So it's about 5 to 10% chance that they might reveal a teratoma later. The chance of not responding to immunotherapy is almost 50%. So almost all patients that do not respond to immunotherapy still have ongoing inflammation in the intrathecal compartment and not a tumor. So it's important to screen again, yes, to consider again, yes, and be very critical whether you might have missed something small, okay, but and even in refractory cases for a long time, you might consider to do a laparoscopy, but to do a blind removal is a measure of despair. and we have considered it. One patient who had a real ovarian teratoma, but then didn't recover at all for 8 months despite everything we threw. And the second one who had a very severe relapse with multi-organ failure and abnormalities on her, some abnormalities on their ultrasound, but not teratoma related. In the end, we decided together with the family not to remove it. And she did recover completely again. And still 2 years later on, we have not been able to identify a teratoma. So I would be very, very reluctant because probably it's just ongoing inflammation inside the brain, and removal of the ovaries is probably not going to help you.
Okay. Mm-hmm. So there are also a lot of questions concerning the treatment. And one of them is, when do you decide to stop the immunotherapy in autoimmune encephalitis?
That's an easy question, but not an easy answer. It really depends on the type of antibody and the severity of disease, the patient, many things. So, for example, for NMDA receptor encephalitis, if the patient responds to steroids and IVIG, we only give them 2 more rounds of steroids after 4 and 8 weeks, and that's it. We don't do any longer treatments. If we need rituximab because they are refractory to the initial treatments and then they improve, we also stop treatment. We never, I don't think any of our we have one patient among our 145 patients that is on regular rituximab because she had a relapse after rituximab. That's the only one. All the others are with any immunotherapy after the acute phase. If we're talking about LGA1, I would say probably 70% of them is on regular immunotherapy. The other 30%, we did discuss it with them, but they refused or wanted to opt for watchful wait. Or we gave them for a few years and then stopped it in consideration with them. Casper-2, we do for a few years as well. So it really depends on the antibody. And it's difficult to share general advice, but let's say that we are often better in starting treatments than stopping them. And for immunotherapy, we should consider what are the risks and what is the patient paying for using these treatments. Mycophenolate can have cognitive effects. Many antipsychotics make patients sedated, make patients gain weight, might change their character while they're already suffering from cognitive deficits due to their autoimmune encephalitis. So it's also important to try to taper antipsychotics, anti-epileptics, and not being too defensive there in keeping them for years on large amounts of medications.
Okay. And then there is one specific question to your LGA1 case that you presented in your talk with the pembrolizumab treatment. Did you test this patient for HLA typing? Did you make an HLA typing?
Yes, we did. I'm sure we did. And I am not sure what the result was. I don't know, just don't know. I should have to look for it. I'm not sure. We, of course, we did discuss this idea about the HLA DR7 to be related to the autoimmune idiopathic autoimmune encephalitis, while the ones with tumors could have other HLA types as well. I'm not sure whether this case is following this discrimination we identified before. And I don't think we have sufficient power yet to tell whether this is actually true. It was not identified by another study from the Germans, from the Müller publication, although they did hardly have any patients with tumors and also identified patients with squamous cell carcinoma as paraneoplastic. Well, we do know that this probably has nothing to do at all and is just a very prevalent tumor. So this is difficult to distinguish.
Mm-hmm. Okay. And maybe we make one last question. So can you comment on anti-SIG4 encephalitis with or without HU antibodies?
Yeah, in my opinion, there is no thing as anti-SIG4 encephalitis. SIG4 is a onconeuronal antibody, which is a marker for a tumor, especially a small cell lung cancer. And it's similar to SOX2. SIG4 is present in patients who have a paraneoplastic neurological disorder or have a tumor of the lung with some creation of antibodies with neuronal targets, but it has no syndrome specificity. And therefore, I would not consider it SIG4 encephalitis. I would say it's a paraneoplastic encephalitis related to a lung cancer, which is also exemplified by the SIG4 antibodies or SIG or SOX2 or HU and so on. So most of them have multiple antibodies, but there's no link to suggest that the SIG4 is at all related to any part of the neurological syndrome or has any pathogenicity.
Okay. So, Martin, there would be many more questions, but I think we should come to an end now. So, first of all, I would like to thank a lot the audience for listening, to taking part in our teaching course, and to be so active in the discussion and to asking so many questions. And there is still the option that we as speakers will answer in the chat function and specifically answer to your questions. So, and thank you a lot also to the speakers in preparing these wonderful talks. And we all hope that we could give you as an audience a very good overview on different autoimmune diseases in the brain and in the myelin. And we also hope that you could learn something about how to choose the right assay for antibody testing. And we also hope that you learn something about possible pitfalls in the diagnosis and treatment of autoimmune encephalitis. So thank you very much to all of you, and we wish you a very successful and good Congress in the next days. Thank you very much.